Hello and welcome. Today's class is Congenital Heart Disease. Congenital heart disease refers to structural problems of the heart or major blood vessels that are present at birth, and it is one of the most common birth defects. So today I'll discuss the general aspects of congenital heart disease. Heart disease can either be congenital or acquired. Congenital means structural abnormality of the hearts which is present since birth, and acquired are the cardiac dysfunction which is acquired later in life either by infection or autoimmune phenomenon. Incidence of congenital heart disease. In general population, around 1% children may have congenital heart disease, and 8 to 10 per thousand live births they have congenital heart disease. Out of this, 3 to 4% is seen in stillborns, 10 to 12% in aborted fetus, 2% in the premature infants. And this congenital heart disease in 40 to 50% cases is diagnosed within 1 week of age, and in 50 to 60% cases by 1 month of age it is diagnosed. The recurrence rate: if one sibling has congenital heart disease, chances of having VSD PDA is 3%, and chances of having tetralogy of Fallot and ASD is 2.5%. Tricuspid atresia Epstein anomaly, there is a recurrence rate of 1%. Now let's see the relative frequencies of the major congenital heart disease. The commonest congenital heart disease is VSD, and this is a cyanotic heart disease. The frequency is 25 to 32%. This is followed by patent ductus arteriosus 12%, pulmonary stenosis 8%, atrial septal defect coarctation of aorta 6%, aortic stenosis 5%, and AV septal defect 2%. Now let's see the frequency of the cyanotic congenital heart diseases. The commonest cyanotic congenital heart disease is tetralogy of Fallot, which is 6%. Then comes transposition of great arteries 5%. Then single ventricle 4%. Hypoplastic left heart syndrome 3%. Total anomalous pulmonary venous drainage and truncus arteriosus 1%. The etiology of congenital heart disease is multifactorial. Here both genetic and environmental factors play a role, and in 90% cases the etiology remains unknown. Let's see the etiologies, starting with the genetic factors. 5% is associated with the chromosomal anomalies. In this, 18 trisomy, that is Edwards syndrome. In this syndrome, more than 90% has congenital heart disease, commonest being VSD, followed by PDA and double outlet right ventricle. 13 trisomy, that is Patau syndrome. The commonest heart disease is dextrocardia, VSD and PDA, and in trisomy 13, 80 to 90% babies have congenital heart disease. In trisomy 21, that is Down syndrome, 50% may have congenital heart disease, and the common defects are AV canal defect, VSD, ASD, which is ostium primum type, though ostium secundum is the commonest type, but in Down syndrome you get ASD, ostium primum type, and VSD. So these are the common congenital heart diseases. Turner syndrome, 40% cases has congenital heart disease, and the common ones are coarctation of aorta, aortic stenosis. And deletion chromosome 22q11, DiGeorge syndrome, also has a congenital heart disease. Some congenital heart disease have a dominant pattern of inheritance. So this is one type of single gene mutation. The examples are ASD, supravalvular aortic stenosis, familial cardiomyopathy. Then osteogenesis imperfecta, aortic regurgitation is common. Marfan syndrome, aortic dilatation, aortic and mitral incompetence can be seen. Coming to gender, The congenital heart disease is equal in males and females. It occurs with equal frequencies, but there is some predominance in the males, that is aortic stenosis and coarctation aorta. So these two has male predominance, and then PDA and ASD has female predominance, though frequency of heart disease is common in males and females. Number 3, environmental etiology. In the high altitude, incidence of PDA and ASD is seen higher, because in the high altitude the oxygen level is low, so chronic hypoxia at high altitude prevents the normal postnatal closure of the fetal shunts, which increases the incidence of PDA and ASD. The maternal risk factors are: if the mother has a congenital heart disease, then 5 to 10% of the babies may also have congenital heart disease. If the mother has diabetes, then chances of TGA, VSD, situs inversus, single ventricle, hypoplastic left ventricle is more. SLE, if the mother is having SLE, then baby is may be born with the congenital third degree heart block. Maternal infections like rubella, there is a high chance of PDA, pulmonary stenosis, VSD, ASD. Maternal mumps is associated with the endocardial fibroelastosis. Now, if the mother is exposed to some drugs like lithium, if the mother is exposed to lithium, then the chances of tricuspid valve abnormalities and Epstein anomaly is more common. With thalidomide, variable different types of congenital heart disease can occur. If the mother is abusing alcohol, then chances of ASD, VSD is higher. Warfarin, anticonvulsants, antimetabolites, phenytoin, valproate is associated with high chances of ASD, VSD and tetralogy of Fallot. Now the baby factor. If the baby has omphalocele, then tetralogy of Fallot is occurring. With imperforate anus, esophageal atresia, chances of tetralogy of Fallot and complex single ventricle is common. With perinatal asphyxia, tricuspid regurgitation, mitral regurgitation and other ventricular dysfunction can occur. Let's see the classification of heart disease. It can be structural heart defects, which occurs due to abnormal development of the heart during the first 2 months after conception. Number 2, functional heart defect. The arrhythmias like congenital heart block and then paroxysmal supraventricular tachycardia are the common arrhythmias which can be seen in children. And positional heart defect, that is dextrocardia. So among these, structural heart defect is the commonest. So we will be discussing structural heart defect in the following slides. So structural heart defect classification. It can be acyanotic or it can be cyanotic. So in this acyanotic heart disease, left to right shunt and obstructive lesions are seen. Cyanotic heart disease occurs with the right to left shunts. In detail, let's see the classification of acyanotic heart disease. This can be with the increased volume load where there is a left to right shunt. Examples are atrial septal defect, ventricular septal defect, AV canal defect and patent ductus arteriosus. Or it can occur with the increased pressure load. Here there is no left to right shunt, but there is a obstruction in the major arteries or vessels. Examples: pulmonary valve stenosis, aortic valve stenosis and coarctation of the aorta. There are regurgitant lesions which are also acyanotic, but the incidence of these regurgitant lesions are rare, and these are usually associated with the syndromes. Examples: with Marfan syndrome, you can see aortic regurgitation. Mitral valve prolapse syndrome, you can see mitral regurgitation. Turner syndrome, congenital bicuspid aortic valve is noted. Ehlers-Danlos syndrome, AR, parachute mitral valve MR, and rheumatoid arthritis AR. So these are the examples of the different regurgitant lesions. Cyanotic heart disease can be classified with the increased pulmonary flow or with the decreased pulmonary flow. Decreased pulmonary flow is with the pulmonary stenosis, and these defects are following the Fallot's physiology. So here examples are tetralogy of Fallot, double outlet right ventricle, pulmonary atresia, tricuspid atresia, total anomalous pulmonary venous return with obstruction, and Epstein anomaly. Or it can occur with the increased pulmonary flow where there is no pulmonary stenosis. So the examples are transposition of great arteries, single ventricle, truncus arteriosus, total anomalous pulmonary venous return without obstruction, and hypoplastic left heart syndrome. NADA's criteria. This criteria was given by NADA, and this criteria is used at bedside to suspect a child is having heart disease. If the presence of one major criteria or two minor criteria indicates the child is having heart disease. So the major criteria are: number 1, systolic murmur with grade more than 3. Diastolic murmur, all the diastolic murmur are pathological. That indicates child is having congenital heart disease. Number 3, cyanosis, and number 4, congestive cardiac failure. And the minor criteria are: number 1, systolic murmur less than grade 3, abnormal second heart sound, abnormal ECG, abnormal X-ray, and abnormal blood pressure. Characteristics of patients with the left to right shunt. So these are the clinical features or conditions in common. So all heart disease with the left to right shunt will have these features. Number 1 feature, you should always remember, there is absence of cyanosis. Left to right shunts, there is no cyanosis. And these children presents with a frequent chest infections, and that is due to decreased lung compliance. And they also have higher tendency for congestive cardiac failure, and one of the common feature will be excessive sweating. And in a baby, suck, rest, suck cycle while they are breastfeeding. The child may fail to thrive due to poor oxygen saturation in the growing tissues, persistent heart failure due to frequent respiratory infections, and the undernutrition. If you examine, the precordial is bulged, that is due to frequent respiratory tract infection and cardiomegaly. You can hear the shunt and the flow murmurs. If you do X-ray, you can see the plethoric lung field and cardiomegaly, and ECG shows right ventricular hypertrophy. Obstructive lesions. The different characteristics of these lesions are: absence of cyanosis. There is absence of frequent chest infections because there is no left to right shunting. A normal precordial shape is seen. There is no significant cardiomegaly. And then chest pain can be another feature if there is severe aortic stenosis. If you examine the precordial in case of obstructive lesions, you will get a forcible heaving cardiac impulse, and there is ejection systolic murmur with thrill, absence of diastolic murmurs. All murmurs are systolic, ejection systolic type. And in the X-ray, you will find a normal size heart with a normal pulmonary vascularity, unlike the shunt lesion. And then ECG, ventricular hypertrophy is noted. Let's see the characteristic of congenital cyanotic heart disease. So number 1 feature will be cyanosis, and they present with the hypercyanotic spells. Hypercyanotic spell is seen in all conditions where they follow Fallot's physiology. Fallot's physiology occurs due to pulmonary stenosis and large VSD. So all disease which has large VST and pulmonary stenosis, they present with the hypercyanotic spells. Conditions which are presenting with the Fallot's physiology are complete TGA with the VST and PS, double outlet right ventricle with the pulmonary stenosis and large VST. Number 3, tricuspid atresia with diminished pulmonary flow. Number 4, single ventricle with the pulmonary stenosis. And number 5, corrected TGA with the VST and pulmonary stenosis. So all these cardiac diseases, they have large VST with the pulmonary stenosis. So clinically, they are presenting with the similar features. So this group of condition following the Fallot's physiology has a similar clinical feature. Other characteristic of cyanotic heart disease are clubbing, polycythemia, murmurs, usually ejection systolic type of murmur is heard, failing to thrive, and then they may have syndromal features. Syndromal features may also be present in the acyanotic heart disease. And there is history of squatting. Congestive cardiac failure is uncommon finding in case of cyanotic heart disease because there is no overloading of the right ventricle. Diagnosis of congenital heart disease. For this, antenatally you can diagnose doing the fetal echocardiogram. And postnatally, number 1, pulse oximetry is done. So this is just a screening test which is done at bedside. So when there is central cyanosis, you give oxygen to the child and see whether the saturation improves or not. If the saturation improves to normal, then this is a lung cause. If the saturation improves but does not extend beyond 70 to 80%, then this is a heart cause. So this test is known as hyperoxia test. Number 2, investigation, you can do X-ray. Here you can see the shape and size of the heart, vascularity of the pulmonary vessels, pulmonary edema, lung and thoracic anomalies can be detected in the X-ray. If you do ECG, then here you can detect the hypertrophy of the different chambers of the heart and then arrhythmias can be diagnosed. Another investigation is echocardiography or Doppler echo you do. Here, intracardiac anatomy of all structural defect can be seen. Hemodynamic data regarding pressure gradients across valves is noted. Cardiac contractility can be seen. Flows and vegetations can also be seen. Number 5, investigation cardiac catheterization. This is done whenever it is needed. Not in all cases, but where it is needed, then only this is done. This calculates oxygen saturation, shunt volumes and pressures. Flow pressure gradient can be detected. Number 6, investigation angiography. For this, indications will be preoperative or postoperative. Preoperatively, you can identify the lesions, different lesions, and postoperatively this is done for physiological assessment of pulmonary artery pressure and pressure gradient. Another investigation, exercise testing can be done, MRI when needed can be done, and then hematology or the screening blood test helps you to detect the anemia. Anemia can be physiological or it can even be iron deficiency anemia. And in congenital cyanotic heart disease, polycythemia can be detected by doing the blood test, and infections which is common in the left to right shunt or the acyanotic heart diseases, infection screening can also be done by doing complete blood count. Coming to the treatment or the management, A is medical management. So medically, treatment of heart failure is done with oxygen, diuretics and ACE inhibitors. In detail, we'll discuss when we are discussing heart failure later. Number 2, prevent frequent respiratory tract infections. Number 3, maintain the required weight and then hemoglobin. So you should take care of the nutrition in these children. and infective endocarditis prophylaxis. This is done by giving antibiotics. Even frequent respiratory tract infection is treated with antibiotics. B. Another modality of treatment is therapeutic interventional procedures are done. So in this, device closure of ASD PDA can be done, balloon valvotomy is done, balloon dilatation of the stenotic valve and coarctation of aorta. Another is blade and balloon atrial septoplasty. And then lastly, catheter ablation of the arrhythmogenic focus by pacemaker implantation can be done. Then finally, the treatment is surgical. So surgical treatment, palliative surgery is done and corrective surgery is done. So usually in congenital cyanotic heart disease, initially palliative surgery is done followed by corrective surgery. Whereas in the cyanotic heart diseases, you can go with the direct corrective surgery if the shunts are not closing. Complications of the congenital heart diseases. Common complications are heart failure, pulmonary hypertension, arrhythmias, infective endocarditis, growth retardation, polycythemia, brain abscess, stroke. Prevention and counseling should be done in a child who is having congenital heart disease. So here prevention can be done by taking good antenatal care to prevent the maternal risk factors, like exposure to different radiations or drugs can be done. And then to prevent infections, you can give vaccinations. Example is rubella vaccine. And then genetic counseling is important. So regarding the prognosis of the child, and then the future outcome or the recurrence rate should be explained to the parents. And folic acid supplementation is done to prevent the iron deficiency anemia, especially in the congenital cyanotic heart diseases. Okay, thank you. I hope this class was useful for you all. Thank you.